It's now my pleasure to introduce our third speaker of our first session, Dr. Loren Hopkins. Dr. Hopkins is the City of Houston Chief Environmental Science Officer and also Chief of the Bureau of Community and Children's Environmental Health at the Houston Health Department. And she is a professor in the Department of Statistics at Rice University. In this dual capacity, having a position again at the Health Department and at Rice, she conducts applied research and uses the results from her research to inform policies in the city of Houston to improve the health of the community. And over the last 18 months or so, she has led the city's COVID-19 data science team. So welcome, Dr. Hopkins.
Okay, thank you, Elaine. The title of my talk is SARS CoV-2 Wastewater Surveillance and Public Health Applications in Houston, Texas. And the first thing I want to do is explain to you that in early 2020, the health department, the Houston Health Department, as I'm sure all over, knew its communities were facing unprecedented challenges as the COVID-19 virus began making its way through our city. And as we have in other crises, we turn to support from our academic partners. Because the health department itself doesn't do research. We try to stay on top of innovative programming. But when things are bordering on expertise that we have available, we're very fortunate to have this academic community around us. We look to them to do that work. And they were essential in Hurricane Harvey, which Houston was very hard hit by, with mapping, modeling, and the hurricane registry, and they were proven essential again in this past year. So before I explain to you what happened, I want to thank each of them for stepping up and prioritizing COVID projects on their already too full schedule and for their selfless dedication. Their efforts have and continue to make a real difference in our understanding and the real success of the Houston Health Department in public health intervention and tracking of the virus. As the lead for the COVID-19 multi-data interpretation team, I identified specific internal and external scientists and data scientists to work with me on a myriad of projects as the need, grew. And these external experts came from Rice, the statistics department, namely Kathy Enzer and her colleagues, in the civil and environmental engineering department, Loren Stadler and her colleagues, as well as Baylor College of Medicine, Anthony Moresso, and also Tony Piedro, a vaccine antibody expert, and Elaine Szymanski, an epidemiologist, biostatistician, and exposure scientist. So internally, I also rely on some very talented staff. But I wanted to acknowledge that team because this is a very big collaborative effort. And it wouldn't be successful without them. So in about April last year, I was contacted separately by Loren Stadler and Houston Water, Loren Stadler from Rice and Houston Water, which is our public works department. And then also from Baylor, from Elaine Szymanski, and who connected me with Anthony Moresso. And they both were suggesting that we used wastewater epidemiology to help us understand what was going on in the city regarding SARS CoV-2. And as I expressed already, the health department uses as much as we can innovative approaches, but we really can't. Our role is not to do research. So my concern in the beginning was that wastewater epidemiology has been around a long time, but specifically how to use it with tracking of COVID-19 wasn't clear, and how it would actually help the health department in informing its decision wasn't clear. But I thought, with these experts and from both entities coming together, that I would give it 6 months. And so the issues became right in the very beginning was how good is the data, because we want to make sure that whatever decision we make with this data is an informed decision and we have confidence in it. And so I thought that after 6 weeks' time, if I felt like, this was still too researchy to be applied, that, we would let that go and come back to it when the research community had figured out, what its applications were. But the story I'm going to tell you today is a big success story. With that huge team and their continued dedication, we have been able to, really understand what the applications are and really very much rely on that information to this day. So this right here is a map of our wastewater treatment plants and also the zip codes that they serve. So a residential community is tied to a wastewater service, service shed area, and that all goes to one wastewater treatment plant. And most large cities have 1 or 2 wastewater treatment plants. And because of the way that Houston grew, we have a more distributed system, and we have 39 wastewater treatment plants. I have to admit, the majority of the time, Houston Water is chagrined by the fact that we have so many wastewater treatment plants, and they wish the planning had been better. But for our application, it's a huge advantage for us because we're able to sample that wastewater and give us information, spatially across the city. Because what you're getting with a wastewater sample is that pooled concentration level, and so to have it for the whole city is useful, and many places across the United States are using that. But we have an even better information system because we have it at 39 places. We also analyze, we branched out after we were successful with understanding what we could do at the wastewater treatment plant level, that we go into this more granular level where we're looking at 75 manholes, 2 jails, 53 schools, 9 nursing homes, 11 shelters. And because some of our wastewater treatment plants are much larger than others, they vary in size across the city, we have the option to go in and actually break down a very large wastewater treatment plant area into lift stations. There are over 450 lift stations in our wastewater treatment plant system. The 69th Street wastewater treatment plant here in Houston is very large. And so to get even more granular within that, we actually sample from lift stations. We have enough samplers to sample from 105 lift stations, which is the number of zip codes in the city. So we, as we progress, we could get to that level where we're sampling 105 at this kind of zip code level. Right now, we have 25 of the lift stations installed. So this is a process overview, and it's really something that, as I said before, is a logistical team that has, we developed this process on how our flow happens. So every Tuesday, the city of Houston's virus load is sampled. And we take 24-hour composite samples at the influent. That means before it's being treated at the wastewater treatment plant at these 39 wastewater treatment plants. So all over the city on that particular day, water comes into one central location, these samples. And that represents about 2.3 million people that were sampling their virus load. We also sampled during the week 53 schools, the congregate living settings that I mentioned, and the lift stations. And they're sampled on different days because Tuesday is the wastewater treatment plant day, schools days are Mondays. The school situation is that those are not 24-hour composites because the kids are only in school. These are our elementary, middle, and high schools. And they're only in school, from say like 8 to 3. So they're the water from that, those locations are composited from 6 a.m. to 3 p.m. And the composites mean that they're, just little samples, aliquots taken every hour so that we have a representative sample at the end in our bottle that represents that time frame. Then the samples in the very beginning, at each laboratory, we sent it to 2 laboratories, one at Rice, our original partner, and one at Baylor, our other original partner. And they independently analyzed the data. The very first month of the project, the labs had not spun up yet. Everything was, they were working on saying, okay, yes, we're going to go ahead and analyze for SARS CoV-2 and waste. We need a little bit of time to prepare. And also because Rice University is a school, they had to go through the process of making sure that they could spin up their lab, given the safety precautions. Baylor was always running. Then, so during that time, we used an outside laboratory and we sent the samples there. I wasn't as comfortable with it because I was, as I stated earlier, I was very interested in the quality of the data. How variable is the data? Can I make reliable decisions on it? If I say this week we need to worry about this part of town, I don't want it to be flip-flopping in the next week, oh, we were wrong. It's actually this part of town. So I really needed to feel confident in it before we could use it. So those 2 laboratories separately analyzed the data, and then they analyzed it in triplicate. So each of them analyzed for different primers, N1 and N2. I used the 2 laboratories, each analyzed for N1 and N2 to detect and quantify the 2 different segments of the viral RNA, the same as CDC would have for the analysis, the clinical analysis of data. And then that information that's coming from those 2 laboratories provided us with concentrations in virus per liter. And then we use the flow rate to get to combine it. We have very good flow rate data from each of these wastewater treatment plants to combine it to get a virus per day for the total community. And then that data would go to a statistical analysis team, which consisted of people from the health department and Rice University, and they would assess that data. So they were able to provide a model that looked at the between laboratory and within laboratory variation of these triplicate samples of these N1 and N2. And then as time went by, with that confidence and changes in methods to get at best practices for how to collect the data, how to analyze the data in the laboratory, and also how to statistically interpret it, we started feeling more and more confident with the data. Then that data, we really began using the data after looking at it through June, beginning in July. We had the confidence in our results. We could really understand what both laboratories were doing. Things seemed to be comparable. And so we began using it. And that's, here's a little graphic of some of the data that comes out of there. And then so we would take that statistical interpretation, bring it to a larger group here in the health department, and analyze that data with a team of leaders in something called a data to action meeting, which would happen every Tuesday. That information was combined with all other data sources that we had, and then strike teams were sent out to different locations based on the data. And still are, actually. This slide is an example of the statistical analysis that was conducted alongside of the clinical positivity rates. And what we learned as we went through the process, as you know, so we're saying, okay, we're taking this viral load data, we're using wastewater. This is not something that we're comfortable with in the health department. We are comfortable with positivity rate. We are comfortable with the clinical cases of the PCR, but how to interpret this and how to use it, how to communicate that to the people that were conducting the intervention. We found that the best way to interpret it, instead of providing them the viral load, is to actually provide it in terms of some kind of baseline. The data, we started feeling very comfortable with the data in the beginning of July, and July 6th was part of the end of a peak for us in the city of Houston. And so we from that, you know, once we understood that we weren't communicating the data and it wasn't very clear in terms of the virus load, we started to provide the data to this data to action team in terms of this baseline July. July was a peak for us. And so our public health intervention folks would say, well, where is that location in terms of the peak? Is it increasing? Is it decreasing? You know, and that was able, you know, that made sense to them. Are we twice the peak? Are we half what we were at the peak? How do we compare to July? So this plot right here, this line right here, this is the wastewater data for the city, and this is the positivity rate for the city. And again, right about here is when we felt like we were understanding the data very well, and we we started using the data from here on out. We can take this model. This will helps us for the city level, but we take this model and we provide the information on the wastewater treatment plant level. And so this is, again, relative to the viral load from July 6th, because that was helpful for interpreting it internally. And then also percent 1 week change in the viral load since July 6th. So you can see that over here is the beginning, and we had this second peak that happened that people are familiar with, that are from Houston, and then it falls off. And this, every one of these lines is one of the wastewater treatment plants. The next thing is that we went into each wastewater treatment plant and looked at the positivity rate data, the clinical PCR data, and see how it was matching up with the wastewater data. The idea is that once we really felt that wastewater was mirroring the positivity rate, that we had this proof of concept that we had this good match, that we could then rely on the wastewater data in locations where we really didn't have good positivity rate data. As you know, positivity rate is based on the a sample of people. Now, the actual number of people that go to get tested, and it's the positive number of PCR nasal swabs out of the total number of people tested. So it's going to vary based on whether people decide they want to be tested or not. And it's biased, whereas the wastewater sample is not biased, because we're sampling everything. And it in the beginning, and the positivity rate was very, very important. But because we have this variability in the number of people being tested across the city, some of the positivity rate plots for a specific area of town would have more data in them and appear stronger than ones that had fewer data in them. So if we could have this proof of concept where we really understood that the wastewater was representing the positivity rate well, then we would feel comfortable about using that data in areas where we didn't have positivity rate data. Now, as we go forward, we realize that it's become even more important, because as people are vaccinated, the CDC has said, you do not need to continue COVID testing if you've been vaccinated unless you have symptoms. So the positivity rate metric itself is completely different than it was previously, because we've been instructed, if we feel okay, we don't need to be continuing to have this testing. And so we only are representing people who have symptoms now. And so for comparison, and to really track the load in the city, we are moving more and more towards using the wastewater data. But as I explained with using that July 6th baseline, I mean, people in the health department, people working in interventions of COVID don't have time to stop everything and try to understand what virus load means for the wastewater. So, we interpret it in terms of, whether it's above or below a peak and whether it's trending up or down compared to that peak. And we also know that people don't know what wastewater treatment plant area they live in. So we had to translate that data to the zip code level. In the city of Houston, every intervention that we apply is at the zip code level. So we now take the wastewater data and divide it into the zip code that it represents. And this could be a combination of 1 or 2 zip codes, or some wastewater treatment plants are just 1 zip code size. And so we have these types of plots for every zip code. And we translate whether the concentration of the viral load placed in the wastewater is going up, down, how it compares to its neighbor, based on the zip code level. And that information is brought together along with all of our other positivity rate information to inside of this cluster analysis report. And the cluster analysis report consists of the information on wastewater, which is listed in orange here. Like on row number 12, it says wastewater treatment plants within the zip code. So it's just identifying which wastewater treatment plant it's located within, the percent of the July 6 copies, the percent of the UK variant within that zip code, the percent of the copies per day by zip code level, and the trend of the wastewater treatment plant virus load in that zip code. The other information provided in this report as it all comes together is the vaccination rate. And because we really don't have very good sociodemographic information from our PCR testing, our clinical data, we had to rely on the data from the American Community Survey to talk about who is making up that zip code. And then we also use this information and rank the zip codes so that we can tell which zip codes are being hardest hit. They have a lot of viral load, they have a high positivity rate, maybe they also have a low vaccination rate, and those are identified as priority zip codes, the top 15 zip codes that we work on in the city. So this is just a little bit of a zoom in of what goes into the cluster analysis report. It's very big. And this is also tells you information like how many clusters are in that zip code. This is the trend. Was it going up or down? The locations, these are made up locations for this report, but we actually provide the locations, the actual address of whether there are 10 or more cases at an address in that and within that zip code, where are all those locations, and that's what the strike teams use to go out. And this is just another example of the cluster analysis report, where it's assessing the positivity rates, and this is the top 15 zip codes. For every top 15 zip code, we actually also plot where the cases are, and we plot the cases in terms of whether they are active cases. These are the ones on the left here. Whether the map shows each positive case in the past 5 weeks, and the clusters are represented by the sizes of the dots. And over here, this is through time. So this would be the oldest map, showing all the cases that were found in that zip code to the most current cases. So we can kind of see the trend of the number of actual cases and where they're located. So a strike team may get addresses of residences, mobile home parks, apartment buildings, and that's where special attention is paid. So that's what we're using the wastewater treatment plant data for in creating that report. We also do that, as I mentioned earlier, this more granular level, location-specific testing, and that is manhole data. And the manhole data is not corrected by the flow at this time. And at the, everything is evolving as we go forward, and we're improving, along with this academic team, assisting us, helping us understand how we can do a better job with it. So maybe that will be included in the future. But for now, the manhole testing is really about comparing the location to itself. So in the wastewater treatment plant, because we can correct for the flow, we can compare spatially. We can compare it in time. We can compare it to itself. We can compare it to its neighbors. In the manhole data, we really compare the data to itself because we don't have that flow. And that would make the assumption that in a specific school, you're going to have the same number of people every time they go. We don't really know what the flow rate is in that school because we haven't measured that. But we do expect it to be similar to the week before, since it's the same number of people. And the information comes back and we report it in the designation as high, low, unclear, or negative. And then we report that information back to the location. This is an example of data. And what you're looking at is recent data. So it's looking very good. We only had 7 high positives. One was a nursing home and the rest were schools. And then some lower positives. And then unknown means it was detected, but unclear near the detection limit. And then a bunch of negatives. So this would be a report. We would separate it out. It goes to the superintendent of schools, who shares it with the nurses. It goes, to the nursing home facilities and the convalescent team, and they're able to see which facility where the virus was detected and then take action, and then work with the health department strike teams on making sure that everything is in line. So when we send something out, this is an example of we send it out to the school and they send us back how many cases that they have confirmed at those locations, and then a checklist that they work with us on whether the school is compliant with their safety plan and whether they think there's an outbreak or not. And so our strike team works with that school using that wastewater data until it falls off the wastewater list or it becomes negative. Yes. And besides providing that list of what is high and what is not high throughout, we also have we provide this time series sort of heat map. And you can see that these schools are high and they have been high in the past. And a lot of these schools have never had a problem. So this is also very helpful in a quick glance. We do the same thing for the congregate living facilities, the same kind of report, the nursing homes. And you can see that they're all looking very good. Possibly one needs, a little, so that's reassuring as we see more blue. And I guess just wanted to wrap up with what we're doing now as we evolved with using the wastewater data. Then we're also now looking very closely at the variants. We do specific primer probes and looking for individual variants in every wastewater treatment plant system. So we track that across the city. We started looking first at the UK variant. We're also looking at Africa, Brazil, New York, California, and India variants. The UK one, I think, we saw it in the beginning, and now it's in every wastewater treatment plant. So we've stopped looking for the UK variant. We know it's here. We know it's everywhere, and it's no longer really useful information. In terms of variants, we will bring in, as we get more confident in that information, that is also informing, because we expect it to be more infectious, that we would send our strike teams and have them understand that, say the India variant is showing up in this location or the California, and that's how that would work too. And thank you. That's all I have.
Well, thank you, Dr. Hopkins. This is really very, very important work for our city, and I know that it's really been a model for other municipalities. So congratulations to you and your team.
Thank you.
Couple of questions that have been raised. One, you mentioned that Houston has a distributed wastewater system. I think you 39 wastewater plants. Were you able to assess wastewater plants outside of the city of Houston proper? For example, perhaps in West University Place or Bel Air?
No, we did not. We have provided technical assistance to the county, to other states, to other cities on what we've done ourselves. But we're just sampling inside the city, which is part of Houston Water.
And I think you mentioned that in your sampling, you have over 50 schools where you're conducting sampling, and I think over 20 nursing homes and other congregate living situations where you're conducting sampling. How difficult was it to get schools and nursing homes to participate in this project? So
the superintendent of schools, the schools that were in are Houston Independent School District schools. And they were selected based on, they were in the high positivity rate areas of the city. And the school superintendent just simply said, yes, we're going to do it. And then she would specifically talk to a principal if we show up at a school to install a sampler and the principal was unclear. So we literally had a direct connection with her. And we've tried to stop sampling in schools as it looked like some of the schools seemed to be no problem. And as vaccine continued, and they said, no, please, we like it. You know, it's really important to us. It's a level of confidence that we have. As a matter of fact, the school sampling was something that we discussed early on internally at the health department. We were wondering if it was useful. We didn't know. There was a lot of people debating how useful would it be to sample the school because the kid isn't there. You know, it's not like they're living there. And what we decided was we're just going to try it. We're going to try it and see if it provides valuable information. It's true. We could be missing something when we say it's negative because maybe, you know, that person didn't use the facilities at the school. But when it's positive, it does provide information to that nurse and that puts her on higher alert. And I think that's how they used it. So we were surprised. When the first data came back, I didn't know that any of it would be positive, and it was.
That's great. I think I saw a slide that answers perhaps or suggests the answers to this question, but have the wastewater sampling data changed with the rollout of our vaccines?
Well, we're seeing way less virus, and that's definitely in the research realm of, like, in the very beginning, we thought maybe we'll be able to distinguish the difference in the viral load from the vaccine, and we haven't gotten there yet. If that is something that we can do, I think that where possibly we're going is really focusing on the variants now. One thing, you know, all these data streams have to come together to be meaningful. One thing that we look at now is vaccine breakthrough. We have two databases. One is the positive PCR database for the clinical data, and we have the immunization tracking database. And when we compare those two, we can find out who is having a positive PCR, you know, after they're fully vaccinated that wasn't positive before they were vaccinated. And then we go out and we ask these individuals to resample, and then we run that sequencing for variant. And then we see where they're living and we check the variant against the wastewater. Are we seeing it in the wastewater? So how much of a variant, how many people have to have it? We don't know that answer now. But, you know, all these lines of evidence, you know, continue to make us smarter about it.
You started your presentation by making a comment about how you want efforts of the health department to really produce actionable findings. And I think you gave one example of how the wastewater data are being used in the schools, at least in putting, I think you said, the nurses on high alert to be aware that there's potential cases. Can you give another example of how the data are being used?
Well, the manhole data is exactly like that. In the jails and the congregate living, that's how it's being used. In terms of the wastewater treatment plant data, when we refine it down to the zip code level, and people are actually deployed to those zip codes based on this data, and those are the strike teams. So, an example that I have is 77036, which is in the Southwest Wastewater Treatment Plant, Keegan's Bayou area. It was the highest rate zip code when we started first tracking the zip codes. And we, as we have these data action meetings, we decide where extra teams are going to go. They are mobile unit. For vaccine, there would be mobile units for testing. They would be door-to-door knocking, providing sanitizer and face masks, where the closest other testing would be, how to quarantine, stay safe within your apartment when you have multiple people living there. So all these kinds of things. So we hire or partner with faith-based organizations and community-based organizations to go into those specific neighborhoods. Then, and that's based on this data, and we keep looking at that data until it falls off the list. And then, because there were disparities, of course, across the city on who was really being hit hardest. And so that's how that data worked and still does.
Dr. Hopkins, there's a question from an audience member about the viral load data in schools and whether or not you've seen any differences in viral loads based on whether among elementary schools, middle schools, or high schools, for example.
That's something that we're going to look into. And now that we have enough data coming from the schools, we really started the school campaign. The first week we sampled was Christmas, right before Christmas break. So we have January to now, and I think we have enough data where we can start to do that kind of work. But yes, that's something that's important. We definitely could refine and interpret better that data now that we have it.
And let me ask one last question before we close this session. I know we're still in the pandemic and you're still doing monitoring, but do you think that there's the infrastructure in place so that in a future pandemic, it's there in order to track some other emerging infectious agent or infectious disease?
Yes, absolutely. That's the plan. I think that, our initial foray into this has been very successful. The leaders in the city are very interested in continuing it for this virus, looking at other things, and antibiotic resistance pathogens, the flu, other kinds of things that would help us understand how to better conduct our public health interventions. But we have all the logistics down, and it's the same water. We just need the analysis.
Great. Well, thank you, Dr. Hopkins, again for your talk this morning, for the answers to the questions that we asked. And really, on behalf, I think, of everyone, we really do thank the Houston Health Department for their tireless efforts. And I can attest to this personally, that you and your team have expended since the start of the pandemic. So thank you again.
Thank you.